These are the disclosures. I consult to various companies, and I will not be speaking about any treatment. If I did, it would all be off-label for newborns. And let me just bring you greetings from my home out west, quite different than here in Chicago, from Utah and Arches National Park. You've probably all heard this issue: the child is not just a small adult. The newborn is not just a small child. And during development, both in childhood and as a newborn, there are some very dramatic effects upon clinical pharmacology and the use of medications. And I think it is not necessarily a cliche. It actually really is a truism that captures the essence of the challenge in using medications in the pediatric population. And I have listed here what I consider some of the challenges in pediatric drug development. I filled up the slide. I didn't have more room, but I will just mention several of these. Some of these we'll go into in a great deal more detail. There are actually very few pediatric study sites with trained personnel. I still encounter protocols that call for drawing, 10 ml blood samples, for example, in children or in newborns, it's clear that nobody has really translated that protocol into a pediatric-friendly study protocol. Endpoints are another major issue, especially in regulatory studies during the approval process. There are very few endpoints that are actually validated in pediatric patients. I have lived my life in academics and watched the evolution of clinical trials and the continued lack of recognition of how hard it is to conduct a clinical trial. A sponsored clinical trial in some institutions is really considered a waste of the academician's time. And we're working within the U.S. to change that attitude because there are metrics for what you need to know to do that clinical trial, and the academic institutions need to recognize that and give them credit. There are actually very few pediatric pharmacometricians as well. I think I know most of them, in fact, and I work with a very skilled lady, Catherine Sherwin, at this time. Development is not a linear process, and I'll show you some examples of that. And it prevents us from making predictions about clearance to develop dosing guidelines. Pain and distress are an issue. Many of our patients are nonverbal. You can try to read their facial cues, but that may be misleading at times. And over again, I wrote an editorial last year about newborns have been left out of numerous studies. And even the drugs that have been studied in newborns are not the right ones. I'll show you some evidence about the development of drug metabolism. And then lastly, at a regulatory level, there are actually very few pediatricians represented. The FDA has an estimated employee total of around 20,000 people, and I think most of the pediatricians there, and it's under 20 for that whole group. Now, the clinical outcome assessments are going to measure the endpoint of that study. And the pediatric patient represents really a unique and sizable challenge. There are 4 types of clinical outcome assessments I listed over here on the right side of the slide. These are reflections of FDA's regulatory pathway. So they will accept patient-reported outcomes. I asked all my babies, how they felt, and didn't get a good response. Then there's clinician-reported outcome, and that has its potential biases, especially if there's problems with the blind of a study. There are observer-reported outcomes. And last, performance outcome measures. Again, in the pediatric patient, a tremendous challenge. So we really have a ways to go in modifying some of our regulatory approach. Biomarkers are used frequently, especially in adult studies, and this is the definition. It's a characteristic measured as an indicator or a measure of normal biologic processes, pathogenetic processes, and the response then to an intervention. And in the center, I put a biomarker is not an assessment of how an individual feels, functions, or survives. Now, those who have to deal with the FDA will recognize these are their criteria for effectiveness. Does it affect how the patient feels, functions, or survives? Well, survival I can measure, okay, but function and feeling, much, much harder in a pediatric patient. Adolescence, you can get some idea, and then you've got the overlay of adolescence, and those of you who are parents will understand what that means. There can be molecular, histologic, radiographic, or physiologic characteristics of those biomarkers. So serum creatinine in place of actual measurements of glomerular filtration rate. C-reactive protein is an index of inflammatory reactions and infection, and so on. Unfortunately, when we go to a regulatory agency with data, very few biomarkers are validated. We measured the effects of dopamine and dobutamine in newborns to raise blood pressure, and then at the end of the day, it was quite unclear whether the blood pressure had any relationship to either survival or cardiovascular status. Blood pressure is an excellent surrogate marker, though, for cardiovascular outcomes in adults, but it's simply not the case in the younger patients. The sites for pediatric study is a challenge. We have a limited number of trained coordinators and investigators at pediatric academic institutions. And pediatric studies, I've been studying medications for a long time now. They take roughly twice as long to enroll as adult studies, and that contributes a great deal to their cost. There's now, at least in the U.S. and in Europe, where we're doing some other work, there's an increasing emphasis on long-term follow-up. That's going to present numerous challenges as well. Young families, or families with young children frequently move, and in the U.S. it can be very difficult to capture that population of patients as they get older. And I mentioned the issue about limited academic recognition, and the sicker patients are generally going to be cared for at academic institutions, and so we need to change that culture if at all possible. The pediatric patient represents a vulnerable population. Those of you who have studied children will understand this. These are the U.S. regulations that have been revised somewhat recently at the Office of Healthcare, OHRP, Office of Healthcare Research Protections. It's covered in Subpart D, and it has some very important restrictions. So you recognize the child, which is considered less than 18 years, they cannot consent for their participation in the study. Generally in the U.S., between 7 and 18 years, we require assent. So we have to have a document that explains what the study's about, and the child who participates needs to agree to it as long as they are cognitively able to do so. And the Subpart D specifies you can carry out a study with minimal risk without the prospect of direct benefit. But almost every pediatric study is what we refer to in the U.S., not so much in Europe, but in the U.S., as a minor increase over minimal risk. And you can do that if there's a prospect of direct benefit, if it's an infection, if it's a viral infection, and this is a randomized, placebo-controlled trial, the child will have a chance of getting an active drug that may improve their outcome and reduce their viral load, for example. You could also conduct that study, though, if that intervention is likely to provide pivotal information about the patient's underlying disease, or for this population, I think their viral infection. Whoop. There we go. This is a relatively old data, and this I want to emphasize reflects the challenge that is before us when it comes to neonatal studies. These are survival percentages by weeks of gestation at birth. And back in the 80s, babies at 27 to 28 weeks out of a 40-week full-term gestation had a very good chance of surviving. However, as you got earlier and earlier in pregnancy, down to 26 weeks and 27, and below, they had a very low chance of survival. However, by the end of 2000, those survivals had risen dramatically. And these data are actually a pretty accurate reflection of what it is today. This is the challenge. I used to use a $1 bill and decided 20 was more accurate. This is a 470-gram infant born just past the half of gestation, and we know very little about how to treat this patient. There are a whole lot of other challenges in the area of pharmacokinetics. I mentioned development, and I'll just mention development, because the changes in drug metabolism and renal excretion of those drugs, especially after they're conjugated, they're not linear. And they also, you can't simply refer to the cytochromes P450 as a homogeneous group, because they mature with different rates. And right after birth, certain of those cytochromes P450 undergo really rapid changes in their activity. And next, it has to do with sampling. Again, I live clinically in the world of small babies, and the blood volume can be as small as 1.5 ounces, 45 mLs in a 500-gram infant. Well, if you add your safety labs, you have room for maybe 1 to 3 pharmacokinetic studies if they're done with exquisitely skilled analytic techniques. And then the pharmacometrician, who's going to interpret those values, has to understand pediatric physiology. I got a paper recently that had a wonderful nonlinear mixed effect model, but they used creatinine at birth. The creatinine at birth does not reflect the baby's renal function, it's mother's creatinine. And it stays that way for roughly 7 to 10 days until finally that creatinine has been cleared, and now it reflects the newborn's renal function. You can't always take the samples you would like. I listed 3 studies here. This has to do with the frequency of painful procedures in newborns. And as you see, as the smaller the baby, the higher the frequency of procedures, painful procedures that are carried out. So you go to that parent and you ask them for consent to take a few blood samples. And for you or I as adults or older children, it's probably a trivial issue. But for that parent who watches their baby undergoing multiple other painful procedures, it's a big deal. Now, we're going to change over to drug metabolism a little bit. This is from Bill Evans and Mary Relling. Bill gave me permission to use this. Just to point out, CYP3A4, 5, and 7 are metabolize more drugs than any of the other CYPs, and right behind it is CYP2D6. Over here, the phase 2 enzymes, so uridine glucuronosyl transferase and the sulfotransphorases, those conjugation pathways, again, account for over half of the phase 2 reactions. I apologize. This PowerPoint and I have been struggling since the airport yesterday. But this is the pattern of transition for the cytochromes P450-3A. 3A7 is the fetal form, 3A4 is the adult form that you're familiar with. You can see that this is a bar graph. This is from LaCroix in Terry Creasel's group in Paris. And the 3A7 is pretty similar between the newborns less than 30 weeks and greater than 30 weeks. But after birth, 3A7 actually increases for the first week and then starts to fall as 3A4 slowly increases, so that by a year of age, most of the 3A is now in the 4 form. So making predictions of the degree of metabolism by 3A right at birth or during the first year of life is a hazardous guess. This is from Steve Leader and Greg Kern's group at Kansas City, and this just looks at 2D6, 2C19, and 2C9 in yellow, and in orange the 1A2 from the fetal period, infancy, on up through maturation. And the message is they mature with different rates. So you're going to, depending on the particular drug, you're probably going to have to measure that clearance at various ages to understand how to dose it appropriately. And then I circled this issue. This is always a fascinating one, that between 3 and 5 years, the liver mass compared to the body mass is much greater, and the effect is the clearance may be twice as fast as it is for adults or adolescents. So it's a challenge clinically, but it's certainly a challenge pharmacologically as well. This is from Bill Engel and Billy Arendt, and this is looking at renal function. And the green dots down here in this line is the clearance of creatinine before 32 weeks and the clearance of creatinine after 32 weeks. 32 weeks to 34 weeks is when you finish making your glomeruli. Okay? And it appears to have a fairly dramatic effect upon then renal excretion. But again, the message is it is not linear. This is from Jean-Paul Guignard and Luzon, and this just looks at GFR that has been normalized to body surface area. And I'll just point out, shortly after birth, 10 ml per kilo per 1.73 meters squared. But look what happens. By 3 weeks, it may have been increased 4 to 5-fold. Okay. So again, very, very rapid changes, very rapid development. We know not nearly as much about tubular transport. It's gaining more study, and that's really quite encouraging. This is looking at beta-2 microglobulin. This is filtered and reabsorbed in the proximal tubules by endocytosis. That's the pathway used by gentamicin as well. Even though we often look at creatinine as a reflection of its toxicity, the toxicity occurs at the tubular cell level. And again, here we are in the preemies, 32 to 34 weeks, and then in term babies, 39 to 41 weeks. This is clearance of beta-2 compared to clearance of creatinine. See that then this goes up and then it comes down because the tubules are somewhat leaky in these babies. Phase 2 enzymes, conjugation. Anybody who's had a newborn or has cared for newborns will realize they often get jaundice. That's the UGT1A1 pathway. But there are, I've forgotten now how many, but we're in the 20s to 30s of UGTs. There's a whole variety of these. And the thing to keep in mind is, first, they mature after birth, but secondly, they're permissive. So they're not as selective for their substrates as the cytochromes P450 are. So there is some sort of crossover. And they also do not mature at the same rate. I've been studying morphine and for the last few years, and it has a very different pathway than does 1A1, and it's cleared by 2B7. And then there's the sulfation pathway. And sulfation is more mature at birth than is the glucuronidase transferase. And here's the data for acetaminophen, and what this represents is the glucuronide divided by the sulfate. So you can see that at birth, most of the conjugation of acetaminophen is by sulfation, but by the time the child reaches adolescence, the glucuronidation has now matured and exceeds the conjugation by sulfation. Morphine is a really sort of a special category, and many of the patients that you will be involved with or you'll write protocols for will be receiving morphine for analgesia. This just shows the UGT conjugation and renal excretion contributing to clearance by gestational age. And what you see is that the half-life goes down steadily as clearance increases with increasing maturation. But one other thing to keep in mind is there's a big difference in the conjugation of morphine, or I should say the effects of the conjugates of morphine. This is the 3 glucuronide sitting here on the 3 position. Down here is the 6 position glucuronide. 3 is anti-analgesic. 6 is a very potent analgesic. Unfortunately, we make roughly 10-fold more 3 glucuronide than we do the 6 glucuronide. And this is work from Jack Aranda. This is very old work, but it's not been replicated to my knowledge at least very extensively. And this looks at the plasma binding at birth using plasma from term newborns. And what he did was he took the plasma and he added the theophylline to it, and then he measured the amount of free and bound theophylline. And because of the difference in protein binding shown here, that is, the adult plasma was 56% protein bound, the term newborn was only 36%. So when the total drug concentration, which is generally what the lab's going to report, was 17 micrograms per mil, in a newborn, that was equivalent to 25 micrograms per mil in an adult. The message is the unbound concentration is frequently higher in pediatric patients, and the effect of the drug will be more closely related to the unbound concentration than to the bound concentration. Solvents and excipients in new drug formulations have been a challenge over the years. Benzyl alcohol you'll find in lots of things to make them soluble and get them into solution so they can be administered parenterally or orally. And when it was used in a saline flush, it caused cardiovascular collapse called the gasping syndrome. Propylene glycol is frequently used in both liquid products as well as emulsifiers. Silver sulfadiazine, and this can cause hyperviscosity, seizures, and apnea. And then polysorbate 80. I don't know that we understand the full mechanism how this happened, but it was responsible for a number of deaths when it was a component of ephorol. This toxicity is often due to immaturity of organs of clearance, causing low clearance. So it's important for new formulations to be checked for their solvents. So there are many challenges in pediatric drug development. The dosing needs to accommodate developmental changes in both drug metabolism and elimination. The endpoints in immature, often nonverbal patients are a challenge to know how to evaluate that drug. They have unique metabolism. The limited blood volume is a challenge to pharmacometricians. And because they're a vulnerable population, that study design has to be tailored to the child, and it will differ from that in adults. And finally, there are limited study sites. We're working to address a number of these challenges, and I think they can be overcome, but they're still significant. Thank you.